Hello, everyone. We are so glad you joined us today. We'll get started and let others join as they're able to. My name is Jenna Groman. I'm the Director of Global Communities of Practice at the Saban Vaccine Institute. And it's my pleasure to welcome you to today's event on behalf of the Boost community and Ariadne Labs, engaging community health workers in COVID-19 mass vaccination efforts. As we give everyone a moment to join the call, please share your name, your organization, and where you're joining from in the chat window. During today's session, we also really want to encourage you to use the chat to share your questions for panelists, share your own thoughts and experiences as we go through the session. I also want to note that today's session is being conducted bilingually. We will have speakers speaking in both English and French and live interpretation available. So please make sure that as you are joining the event today, that you choose the language that you want to listen to through the interpretation button, either English or French, to make sure that you are listening in your preferred language as the speakers are talking through their portions of today's discussion. This event is a part of the Global Mass Vaccination Site Collaborative. The Boost Community and Ariadne Labs, a joint center for health innovation at Brigham and Women's Hospital and the Harvard School of Public Health, are pleased to introduce you to the Global Mass Vaccination Site Collaborative. This is an initiative aimed to provide resources, tools and experts available to assist mass vaccination site operations in low and middle income countries. We feature an open access website that includes tools, guidelines, and other instructions for setting up and operating mass vaccination sites. We also have a learning group on the Boost community where you can access these tools and connect with other peers and experts to ask questions related to mass vaccination rollouts. So we hope you join us as we move forward through this initiative. Before we begin today's event, I want to put up a quick poll question to see what everyone's experience is and really what you're hoping to get out of today's event. So I am launching a poll question. It is, have you worked with community health workers to drive demands for COVID-19 mass vaccination? And would love to have you all answer this individually. Either yes, I've done this successfully. Yes, but I've had challenges in doing so. No, I'm looking for new strategies, or other. And if your answer is other, would love to hear your response and reason for choosing that in the chat window. And we'll give just a moment for everyone to answer the question. And for those of you who have just joined, we do have a poll question launched on the screen that we would love for you to respond to before we move forward. Great, thank you all so much. I'm going to share the results quickly and then we'll introduce our speakers. Of the individuals we have on the call today, almost half, 43% have used community health workers to help drive demand for COVID-19 mass vaccination. The others are either looking for new strategies or some reported other, and would love to hear why you chose other and really what you're hoping to learn from today's call if you want to share in the chat. Great. And so I just want to now introduce Rebecca Alban from Village Reach, who will be starting us off today and talking a little bit about what Village Reach is doing. Rebecca, I'll pass it over to you.
Thanks so much, Jenna, and greetings, everyone. Thanks so much for joining us today, wherever you are in the world. We at Village Reach are very excited about this opportunity to share our work through the Boost community. So as Jenna alluded to, in our presentation today, we will share our experience working with community health workers to improve COVID-19 vaccination outcomes in the DRC. We will explore this connection between community health workers and high volume sites and illuminate some of our successful approaches that our team at Village Reach has taken to increase demand in communities for these sites. Some of our other objectives for today's presentation are to highlight community health workers' unique ability to educate and influence behavior. And in that, we'll explore more specifically, what's the added benefit of someone having an interaction with a community health worker versus getting information just from the radio or mass media. We'll also explore some different strategies in which community health workers can actually mobilize people for vaccination. And by explore, we mean we'll talk about what worked in our approach and also what didn't work in our approach and some of the challenges we encountered. We'll also demonstrate some how engaging with community health workers can lead to better outcomes and actually share some of our recent data that we have on that. And lastly, we look forward to engaging with all of you in some discussion on our work with community health workers. It was exciting to see through that poll that almost half of the folks on the call today do have some experience in this area. So we look forward to getting some feedback from you all. Maybe we can learn from each other based on our experiences and have a meaningful exchange at the end of the call. Next slide, please. As Jenna mentioned, my name is Rebecca Alban. I am a health systems manager at Village Reach. I support our programs in community health workers, supply chain, and generally in improving access to healthcare in our core countries, which are Mozambique, Malawi, and the DRC. And I'm joining you today from Spain. And Carla Toko, who will be our lead presenter today, is based in the DRC. She is our manager of advocacy and communications there and has been leading our recent work with setting up our high volume sites and also manage the efforts to work with our community health workers in that area to increase vaccine uptake at those sites. I'm also very pleased to share that we have a special guest joining us later in the presentation, a community health worker named Cecils, who will join us for a few minutes from the DRC as well to share a bit about her work and her role in this work, talk a little bit about her experience, share some of her perspectives, challenges, and reactions to doing some demand generation work at these high volume sites. So we really look forward to hearing from her later in the presentation. Before I hand things over to Carla, I do want to start us off with a bit of context setting about community health workers in general. Next slide, please. The WHO and global community have set a COVID-19 vaccination target of 70%. And unfortunately, we are at the moment very far from reaching that target for many reasons. But a lot has to do with community level perceptions about COVID and about vaccines. COVID vaccines are not like other health services. It's a new service, it's unfamiliar, which means there are heightened levels of fear, mistrust, and lots of misinformation. And we think that this requires a special approach and special strategies to communicate about it. We know that mass media and social media can play a very important role in educating the public, but in the end, these are one-way tools. They're more like marketing tools. And what we've seen is that on the ground, there's nobody talking to individuals about vaccines. There's no one who can directly address fears and answer questions. And so we identified this gap and we decided to engage community health workers to fill this gap. Why did we do that? Because we recognize that community health workers are key connectors that link communities with health information and health services. By definition, community health workers originate from the communities that they serve. So they're very familiar with the community beliefs and norms and their culture. And they know the rumors that are flying around about vaccines and about COVID. So they're really on the pulse of those community perceptions. Community health workers also have credibility in their communities. They have that shared lived experience that fosters trust, which is very important in having these conversations. We know that with the right training, community health workers can employ strong communication skills to educate populations, to reassure them, and ultimately to influence their behavior. And we also know that they can create strong positive social norms around COVID-19 vaccination by refuting myths, providing facts, and ultimately building confidence in the safety of vaccines. They can also build awareness about where and how to get vaccinated. So providing some of the logistical information. And Carla will talk more about that when she goes into our community health worker referral model specifically. Next slide, please. Community health workers have routinely played critical roles in new vaccine introduction, and the case for COVID-19 is no different. Community health workers can and are being used to identify target vaccination groups, to track and follow up on vaccine defaulters, also supporting folks with follow-up to get that second dose, to support the actual service delivery of vaccines, and of course, participate in community engagement and mobilization. And that's the piece that we're going to focus on a lot today, the community mobilization, and specifically how community health workers can be used to correct misinformation and have those difficult conversations about vaccine hesitancy. Next slide, please. We know that community health workers offer huge potential to promote vaccine demand, access, and to break down barriers for health equity. However, to unlock this potential, community health workers also require certain types of support in order to be able to carry out their jobs successfully. However, in many countries, community health workers are not recognized as part of the formal government health workforce, and thus are not prioritized for things like receiving PPE or receiving the COVID vaccine, or even receiving training on COVID-19. And it's our view that community health worker performance is optimized when community health workers are recognized and remunerated in a way that is matched to their job descriptions, that they are appropriately trained and supported with ongoing supervision, particularly with new roles and tasks that have been added as a result of COVID. Community health workers also need to be protected. Due to the nature of their work, they face a heightened risk for contracting COVID-19. So things like PPE and vaccinations should be provided to community health workers in the same way that they are for other health workers. And another way to optimize potential for community health workers is to consider them in administering vaccines and not just participating in demand generation. This isn't something we're going to cover much in this webinar, but just a side note to highlight that there are countries where this type of task shifting is happening, where community health workers are leveraged as vaccinators themselves. And Malawi is a good example of this. So this may be a topic for another webinar, but it is a strategy that allows countries to maximize their existing health workforce and potentially expand vaccination coverage while leaving nurses and other health techs more available to carry out other specialized health delivery tasks. So that's it for my introductory comments. I think now I'll pass on over to Carla to dive into our work that we're doing in the DRC.
Allô, vous me voyez?
Hello, you can hear me?
Merci Rebecca. Et bon,
Thank you, Rebecca, and hello, everyone.
Est-ce qu'on pourrait aller
Can we go to the next slide, please? Okay.
Alors, je vais commencer,
So I'm going to start by giving a bit of background on the work of Village Reach with healthcare workers for the vaccination sites that we've set up against COVID-19. So, the reason that we worked in these areas is we saw a low vaccination coverage, and we wanted to make sure that the vaccination services came closer to the areas that were being covered. And between November 2021 and now, we were able to set up 4 different sites, vaccination sites, in public areas that are very easy to access with a lot of people who normally come to those sites. Those 4 sites are within Kinshasa, in Gomba, in the middle, really in the center square, Kalamu, where the site is actually set up in a sort of a roundabout where there's a lot of traffic passing there. Then also in one of the large Kinshasa markets in Masina, and then in Djili, which is in a soccer stadium. And these are in areas that are actually rather highly populated. The reason we chose Kinshasa is because it is an epicenter for COVID-19 in the DRC, and it has about 15 million inhabitants. These sites actually use 2 different vaccination strategies. First, the fixed vaccination, and then outreach vaccination teams. The fixed vaccination site functions is the base of operations. And this is where actually people will go. We've seen people actually move into these sites, or they will come actually from very far away to wherever a fixed vaccination site is. We found that it's been of use for people who are working in those sites and aren't able to actually leave their offices. So we actually set up the healthcare workers at these sites to be able to generate needs and the demand within the community and to have a direct contact with the community. Our healthcare workers are with us at all of our sites. They were identified within the healthcare zones, and they're there to help actually direct the community towards the locations that were put into place. So this is how the healthcare workers in our outreach vaccination teams were set up. Next slide, please. Yeah, next slide. Okay. So we set up a referral system for our community sites. We had people who were working in different areas outside of sites, and they have experience actually guiding people towards different areas. And we employed our community healthcare workers to help go out into the community to be able to provide referral to these sites by first giving them a little bit more awareness training, answering questions. And they have a specific itinerary that they would cover. So public spaces around the sites and households. And within their work, they brought information cards and referrals. So they also had a rumor collection form. So in addition to their pre-registration form, they also had the rumor collection form. That was really great. It was set up by our 2014 commission. It allowed us to be able to counter some of the rumors that are distributed. And then after that, we also had tokens for them to take for their referral to the site, which actually gave a person, or they would actually write the name of the person who wanted to become vaccinated after they had done some awareness building, so that once they arrived to the site, they were already identified as somebody who had been sent to them by our healthcare workers who were doing outreach in the community. Because we really want to make sure that we have data based on which we can assess the success of our healthcare workers and their outreach work. They were also, able to do this outreach and this awareness training actually within households. So we're able to actually aggregate some of the data showing where the awareness building happened. Next slide, please. So, for establishing the sites in order to prepare for this, we did training that was given to our healthcare workers and our community workers, and they were trained between December 2021 and March 2022, and we were able to adapt them to the new training curriculum based on some of the data had collected prior. We found that actually the trainings were quite heavy, and when we tried to do them remotely, this was actually causing a lot of information to be lost. So it was great to be able to do it in person and to have this connection with our community health workers. And so these training sessions allowed us to adapt actually our curriculum that would be a little bit more practical in its application. And especially when it came to their ability to build awareness within the community. So we modified some of the information to become more practical, to be more targeted towards fears and biases. And we were able to use this information for the 3 other sites that were opened later. And Kinshasa's provincial health department actually also requested the training curriculum so that they would be able to replicate this sort of training with their own community health workers, and then in general for the population for COVID-19 vaccination to improve coverage. Next slide. So since we started in November, throughout this system that we had implemented, we assessed the way the actual ability to create demand, and our objective led to more than 50% of vaccinations across all 4 sites. And what we also saw is that there was really an improvement over time within the performance of our community health workers, that they were actually able to see that it was a combination not only of training, not only of being able to combat false information, but it was also being able to respond to questions that the community had and wanted to be able to ask somebody directly. And then also being also saying the total number of those that were actually oriented by our community healthcare workers to the site, we see that they were able to they were able to bring a high number. And on each site, you see the number of those that were brought in. And it's interesting because there was a change of strategy, and the strategy by making our training more practical, we were able to actually also adapt it on a day-to-day basis to make sure that it was more effective over time. So next slide, please. So this work was not done without having to face some challenges. I won't go into all of the details because we do actually have one community health worker with us who'll be able to give her experience. But regardless of those results that you saw, we saw that acceptance for vaccination just does not happen very quickly. It doesn't happen overnight. So sometimes it requires us to go back to a household or to a person several times before they can become convinced. We've noticed also another challenge, which is that our community health workers had emotional and physical burnout through their work. Given the context, the current context, and the high risk that they encountered people who did not want to listen to what they were saying at all, that were quite against the information that they were trying to share. And the climate can sometimes be antagonistic in RDC when it comes to having two different kinds of ideas. And then we also had the challenge of the weather. And so, of course, because they're always outside, and it's either raining or very hot. And so in RDC, we found that they did experience also some physical burnout as well as emotional. In addition to that, some of the material that was given to people to be able to be referred to a particular site was lost, or those referrals were underreported, meaning that the data wasn't necessarily accurate. And of course, as was said before, there is a lack of recognition, official recognition, and salaries as a part of our health workforce for those community health workers. And one of the things is that when we have the underreporting of referrals that can't actually show the success of our work, that is a problem. But as we said before, not recognizing and not really having the official remuneration of our health workforce, particularly our community health workers, is a challenge. They play a very, very important role in COVID-19 vaccination and in any sort of endemic disease that needs to be, as far as awareness building, that needs to be distributed in the community. They're very, very important to this. And they are able to bring, and they're able to bring such a benefit that they need to actually be remunerated in a way that is matching their work. And next slide. So what we learned is that during this COVID-19 pandemic, and particularly with vaccination, is that we saw concretely that the community health workers were able to help with false information that went out around this pandemic, and we're able to help low and middle income countries, as RDC is labeled. And the thing is that the CHWs are actually able to provide this accurate information, but in a way that means that they are kind of representing healthcare professionals. What they do is they show an example. First of all, they need to be vaccinated, and then that in itself does encourage other members of the community. And then that is reinforced by the formal training that they're given to be able to respond to the very specific questions that some people can ask. A lot of people still have a lot of hesitancy regarding the vaccine, and being able to give them a lot of information to be able to interact has been and has a positive impact. And they are able to actually adapt that information to deliver it to the community by being the person that is believed more. That is, someone that the community already has faith in. And whereas some healthcare professionals, they believe maybe giving them false information, so these community health workers are actually trusted at a higher level. And we have noticed that over the 4 sites, that about 15% of the people who were vaccinated in Shasta we wouldn't have been able to get those results at all if they had not been approached by our community health workers. And so that's the information that I wanted to share with you. Thank you for your attention. And now I am going to give the floor to Cecile so that she can speak on her experience as a community health worker herself. Thank you. Thank you. Thank you for your presence, and thank you for all the kind things that you've said about community health workers. One of the things that I did was I went door to door to perform awareness building. It was specifically interesting to see people that weren't used to having this sort of approach to awareness building. And by engaging with them, one of the things that I most often had to address is that the vaccination itself was not dangerous to their health. Some people that hesitated to become vaccinated, I would actually give them the reference to actually help them go to the site, but I would explain to them what kind of doses we had, what kind of vaccines we had, whether it was Pfizer or Johnson & Johnson, because there was a lot of concern about that. A lot of them wanted to be able to choose the vaccine that they would take. When I finished on the 29th I would also write down, like, for instance, that they had to go back on the 29th of April for their second dose. And then they would say, okay, Mama, give me the referral and I will go, and I would put the dates on there, and I was able to convince them all to go. And the thing is that some people wanted me to actually go with them. And they wanted to make sure that I had actually done it myself. So I would send them to the centers to get vaccinated. And then they would come back to the bus stop to see me, and they would show me their card. They would say, Maman, see, I've been vaccinated, I've gotten my card. It was interesting to see the pride that they had in that. So there was a sort of follow-up with us. Some people would not come get vaccinated because they said that the products themselves were false, that it wasn't real, that the disease itself wasn't real. There was a lot of mistrust in the community. And I would always have to tell them, the biggest thing we're trying to do is take care of you, and you have to take care of yourself. If later you have the disease, it's too late, really, for you to prevent it by getting vaccinated. Vaccination is not obligatory, but it is something that is going to take care of you and of us. And I saw when some people started to see the benefits of vaccination themselves, how it protected not just themselves, but their families. But as I went, into the field, I saw people that were still very suspicious. They were suspicious specifically of the products being produced and imported. And they would sometimes they would be paying $300 to just buy a vaccination card, and they would say, "Maman, I just need the vaccination card to be able to do this or that or travel here or there." And I would have to explain to them, no, it's about the disease. It's about protecting yourself and others. And I would be able sometimes to convince them to go and get vaccinated. And I would say, either you go get vaccinated or you keep yourself quarantined. You make sure that you stay away from people. And often I was able to convince people, because when they came to me with their cards that they had bought, I would say, that's not correct, that's not right. What you need to do, you need to think about, because they really, I would have to ask them, why do you think it is that you need to get vaccinated? And they're like, they didn't understand, they understood the idea of the vaccination, but they really had lost a lot of trust in the companies creating the vaccine. So one of the things I was able to do, after a lot of awareness building with some of these people, able to convince them that they could trust me, and that what we were trying to do was save lives, and they knew that that's what my goal has always been. That's always been my work. And, once they understand, right now, vaccination is completely free. It's something that's being done to completely cover everyone. I don't see why you would pay money to get a vaccination card. And it may be one day that we will have to pay to get our vaccinations. So it's best to protect yourself now. But my experience for myself has been to be able to have this connection with my community, to be able to start to change people's minds, and to help people live in dignity and in good health. From 2008 to 2022, I have worked within the community. I have worked as a community health worker and continue to struggle and fight for my community, to try to convince my community to become vaccinated, to do everything they can to protect themselves from endemic disease. And right now, we are very lucky to have these vaccinations and to be able to get my community vaccinated. And my goal is really to get everyone vaccinated and to do my best. Thank you. Thank you very much, Mama Carla. Mama Cecile?
Thank you so much. It's wonderful to hear from all of you. And thank you especially to Mama Cecile for taking time out of your really already busy day to join us and share your experience working with the community. I think it's just invaluable to hear directly from you as part of this conversation. We've had a number of questions come in through the chat. I want to encourage everyone to continue sharing your questions for the presenters, and we'll just talk through several of the questions we've had. You please also share some of your, thoughts and experiences as to, does this reflect what you've seen on the ground and working in various communities? So our first question is from Mumuni Abdu. I'm going to direct this to Carla. I would like to know the achievement, results versus target, in order to better assess the impact of this strategy. And as a reminder,
I'm sorry, can you repeat that question just once more? The achievements of?
Yes, I would like to know the achievement, the results versus the target in order to better assess the impact of the strategy. I think.
Oh oui,
Madame
je voulais en
Sioni.
fait demander si on pouvait répéter.
I wanted to ask you if you could say it again. Yarla is asking.
Sure. He says, I would like to know the achievement, results versus target in order to better assess the impact of the strategy. And I think what the question is trying to get at is, how are you assessing the success of this strategy? What are you looking at, and what were your targets for success, and what did you achieve?
Okay. So I will answer in English. So for us, in terms of success, because as we set up the sites, we had goals to reach at least 400 people per day for our sites. But given the context in which we are in DRC, we found that even for each of our sites, who are averaging today for each of the sites at least 110 person per day. But it's even the highest among all sites that are vaccinating in Kinshasa, because there's still quite a bit of hesitancy around COVID-19. So for us, it was a matter of reaching our targets. And what actually led us to open more sites is that to 4 sites now we're able to reach our goal of at least 400 per day, because each one of them are averaging in the hundreds. Now, for us to better evaluate what the community health workers are providing, as long as we are meeting our daily goals, then we're very much satisfied with what they're providing us, because we know that even if we say we want 100, first of all, it won't be possible for us to have all people oriented to the sites by community health workers. Word of mouth, based on some of our client exit survey in some of the sites, have actually been one ways in which many people have come to the sites as well. And so community health workers, as we saw in some of the sites, it's really varying from 30% to 73%. So for us, we're telling our community health workers, if each one of them can bring at least even 10 people each day, then it will be helpful. To us, even one person that they bring is already a lot, given the context in which we are working. And so there are days where more than 80% of people who have come to the sites were oriented by community health workers. Some days where we're seeing, it's only maybe 20%. Obviously, when it rains, it also makes the work very difficult, because people here don't like to go out, when it rains. So for us, as long as we are meeting our daily goals of reaching at least more than 100 people per site, so that at the end of the day, to all the 4 sites, we can reach at least 400. We're very much satisfied, but we also understand that it's not only community health workers who will bring us, all the people. What we've seen is that clients who come to our vaccinodromes, once they're satisfied with the service, they also refer to us other people. So it really takes efforts from everyone, and also other strategies that we've used to media to also refer other people to the site.
Thank you, Carla. It was a little hard to hear you through that response. So I'm going to direct the next question to Rebecca. How can community health workers be used to improve health systems in the long run? And also, to piggyback on that a little bit, how can we use them and integrate them into the health system, also to prepare for future mass vaccination needs and future, potential future pandemics as well?
Thanks for the question, Jenna. Just speaking quite generally to the first part of the question about how community health workers can be used to improve health systems, I think the unique thing about community health workers is that they have the ability to both affect the demand and the access side of health services. So as we talked about today, interacting with communities and being closer to them, communicating and imparting information on the ground level like nobody else can, and using their unique positioning in communities to do that and to create more demand, not just for vaccines, but for all types of health services that need to be talked about in communities. But then also on the service delivery side, they have the ability to bring services closer to the people. We hear so much about access barriers, physical barriers that people have to get to health services and needing to travel long distances. Community health workers are that bridge and can create that bridge to bring services closer, bring them out to a health post that minimizes the distance people would have to travel, going actually door to door and being proactive about service delivery. Those are the types of things that community health workers can do to really make health services people-centered and make services more convenient and user-friendly. So I think it's both of those, service and access end of to improve health systems. Yeah.
Thank you, Rebecca. Carla, I'm not sure, I want to make sure we're able to hear you with this next question. So the next question came in with the collection. What are the collection tools you use to collect rumors? And who is in charge of doing this? I think that's speaking towards some of the work that Maman Cecile was talking about.
Oui, vous m'entendez mieux?
Yes, can you hear me better?
Yes, thank you.
Oui, alors pour au sujet des rumeurs, en fait,
So, regarding rumors, we had a form, we actually had a paper form. It wasn't anything that could be done electronically, but it was something that the commission set up to try and really collect the rumors that were circulating, things that people were actually starting to share between themselves. And so during a conversation that a community health worker would have, they would ask them, what kind of things they had heard, what sort of things they had told them, or they would just offer this information. And then the community health worker would then note this information within their rumor collection form. And that allowed us also for follow-up, for further adaptation of our techniques, to be able to help the community health workers later on by doing a little bit more work to help them respond to these rumors when they came up. Or find somebody that they would trust that would be able to refute this rumor. So normally, this would happen with a supervisor or even with somebody else in the community to really be able to bust through those myths. And it's true that given that at our sites are in public areas where there are a lot of people passing by, well, we don't actually have the opportunity to see these people again because it's just quite busy. So this rumor collection form that our community health workers use enabled people to come armed to be able to deflect information, and to be able to give information directly to them that responded to these rumors that had been going around. So it was a method for us.
Thank you. And I'm curious as well, did you encounter any hesitancy from the community health workers themselves in being involved in COVID-19 mass vaccination efforts? And if so, how did you address this through your work and training that you did? And that might be appropriate for either Carla or Rebecca.
Thanks, Jen. I can start and then I'll have Carla add on anything else. It's an interesting question because yes, we did. I was part of developing the training curriculum, and when we were looking into sort of the needs of the training, we started with COVID-19 vaccination, but then after speaking to some of the community health workers, we realized that there was a large proportion of the CHWs themselves that were not vaccinated before the start of the training. So we immediately kind of changed gears and realized that we needed to do some more internal reflecting with the community health workers themselves and make sure that a lot of the information that they had was accurate and current. And so actually the training started with a number of sessions of community health workers who were vaccinated, sharing their stories, sharing why they were vaccinated. And that was the first part of the training, really, just to level set and get everyone on the same page, and training the community health workers that they were going to have to lead by example in the conversations that they were having. People were going to ask them to see their vaccination cards, and if they didn't have them, they would kind of lose that trust and credibility. So some of the training was around how to, be a pillar of your community and lead by example. And part of that was being vaccinated themselves. So that was a big focus in our training.
Thank you, Rebecca. Carla, any other thoughts on that?
Yes, I think that's when it came to the training, yes, effectively. There were other items also that we adapted that was specific to the vaccine. And also we were able to adapt it better to the experience that we heard from them. To know that there were a lot of information that especially when it came to demystifying, to myth busting, there was a lot of information that was being shared on social media. And that's how, through sort of that information that we gathered through the trainings, we were able to adapt them as well. And also through the questions they asked us. Sometimes they would ask us, how were the vaccines developed so quickly? They had their own questions, or the questions that they knew that they would be asked. And about the preference in number of doses, whether they would have one dose or booster, and so and just to be able to talk to them and let them know actually all the vaccines are okay, because some of them had opinions on just one vaccine or another. And also helping them know that they had a choice, that when they talked to the people in the community, that they could help them make their choices as well. And I know that the community health workers, played a big role in helping people, have less fear regarding the way that vaccines were developed, and specifically on one specific vaccine or another. And then really encouraging people and letting them know that they had a choice and that they were safe regardless of what choice they made. That was very important.
Thank you so much. And I know we're nearing the end of our hour, so I just want to say thank you so much to all of our presenters, Rebecca, Carla, and Maman Cecile. Just so grateful that you were able to join today and share so much expertise with us and the community. Just a couple notes before we close out today. First, as I mentioned earlier, this event is part of a broader initiative, and we invite you to stay engaged with the Global Mass Vaccination Collaborative. You can explore our website at globalmassvaccination.com, as well as join the learning group in the Boost community to connect and learn and continue this conversation. We did not get to all questions today, but we will follow up with responses on those. We do have another great event lined up next week, which is exploring how the rescue initiative in South Sudan worked to scale up COVID-19 mass vaccination while also working to maintain non-COVID vaccination efforts in South Sudan. So please register today. We've put that link in the chat window. And please take a moment to take our survey as well to share feedback on today's events and help shape future events. And that link is also in the chat for you. Before we close, I just want to also note that the Saban Vaccine Institute is now accepting nominations for the 2022 Gold Medal and Rising Star Award. Each year, Saban honors individuals and teams who have made extraordinary contributions to immunization and global health. So please help us honor this work by submitting a nomination. And there is more information through that link in the chat window as well. And we hope to hear from you through that. So again, I just want to say a thank you to all of our presenters and to all of our attendees today for joining. And I hope you have a wonderful rest of your day. Thanks so much. Bye-bye.